To introduce our next speaker, to discuss some of the abstracts at the liver meeting in PSC and PBC, we'd like to invite Dr. Kowdley back again from Seattle, from wet weather to wet weather. Kris?
Thank you, Steve. It's always a pleasure to speak at this meeting, and I want to thank the organizers for an opportunity to review the abstracts on PBC and PSC, and I've decided rather than to race through 15 abstracts and put your head spinning with numbers and tables, I would pick 4 abstracts and go into them in some detail. I'm going to cover long-term results with obeticholic acid, a new FXR agonist that had a phase 2 trial, the role of FibroScan in PSC, and the sort of the hot topic, which is about using fibrates as third-line therapy in patients with PBC. Here are my disclosures. So obeticholic acid is approved for primary biliary cholangitis as second-line treatment. It was approved in 2016. The initial therapy was a 52-week placebo-controlled trial. Patients then entered a long-term study, so it was a 1-year randomized trial with placebo, and then there's a long-term safety extension where patients were given open-label therapy. And what this gives us an opportunity to do is to look at what is the durability of the biochemical response, how safe is the drug, how well is it tolerated, and are there any changes in transient elastography that might suggest changes in fibrosis or remodeling in the liver. So here's the abstract. This was a late breaker presented by Fred Nevins, and this is a 4-year open-label extension study of OCA. Seem to be having trouble clicking forward. Okay. So here's a study design from the original POISE trial. As you may recall, patients were randomized to either placebo, 5 milligrams, or 10 milligrams, and then the 5 milligram dose had an opportunity to up-titrate after 3 to 6 months based on the patient having achieved the biochemical response. The inclusion criteria are the so-called POISE criteria, which is an alkaline phosphatase greater than 1.67 times the upper limit of normal. Bilirubin had to be less than 2, and the patient either needed to be on a stable dose or unable to tolerate UDCA. So here's what happened to the patients. There were approximately 200 patients in the double-blind phase. About 193 went into the open label, 158 completed the 4-year period, and 116 completed 5 years. So this is really a pretty good data set for a large number of patients being exposed to this drug for this long. So 76% of the patients completed the protocol, 82% completed 4 years, and 60% completed 5 years of treatment. And 52 patients who had received OCA in the double-blind phase completed 6 years in total. So here are the baseline characteristics, pretty typical of our PBC population. Majority were women, majority were white, average age is 55. Duration of PBC was approaching 10 years. 63% of patients had a history of pruritus. So this is a very complicating issue when you're trying to understand pruritus as a side effect or an adverse event of a drug, which is common with FXR agonists, but you also have a very high rate of pruritus baseline in the population. The dose of urso was standard. The alkaline phosphatase mean was 317. And when you look at liver enzymes, bilirubin shown here in micromoles per liter was 11.5, and the rest of the liver function tests like albumin and bilirubin were okay. Direct bilirubin was 5.3, and so this is a compensated population with a significantly elevated alkaline phosphatase. And here's the primary endpoint. When you look at alkaline phosphatase being achieving less than 1.67 times the upper limit of normal, total bilirubin less than upper limit of normal, and a reduction of at least 15% from baseline, you can see that the response was pretty durable. The percentage of patients who achieved this response stayed stable over time up to 72 months. So 46% of the patients met the primary endpoint after 12 months, and after 48 to 72 months, the proportion of individuals meeting the primary endpoint sort of inched up a little bit and went to 50 to 56% meeting the primary endpoint. So OCA was associated with a gradual increase in the percentage of patients reaching the response, and the response was durable. And this shows the mean changes in alkaline phosphatase and bilirubin with OCA treatment over time, and you can see that ALP, or alkaline phosphatase, comes down and stays at this point, although it is also important to note, and this is an interesting discussion about how this drug works, that normalization is uncommon and there's not a continued decrease in alkaline phosphatase. They sort of achieve that goal and stay there, but you can see there's quite large variability. Here's the bilirubin, again showing the total bilirubin levels remain stable and within the normal range for most patients. Now, the early reductions in ALT, AST, and GGT were sustained for the duration of treatment. So you can see that here, liver enzymes coming down, GGT coming down, and stayed pretty consistent with maybe a gradual decrease in ALT over time. Now, you want to measure inflammation. You think that this is an anti-inflammatory drug, possibly antifibrotic in PBC. And you can see that CK18, which is a measure of apoptosis, sort of comes down and stays a little bit low, but not dramatic. Highly sensitive CRP shows this kind of trend. And interestingly, IgM levels come down. And IgM, of course, as you know, is associated with a monoclonal spike in patients with PBC. And so this suggests that the autoimmune burden is being reduced, although secondary markers of inflammation not as obviously so. So the way FXR agonists work is they are ligands that bind to these nuclear hormone receptor called FXR, and they trigger a variety of things, particularly affecting both cytochrome P457A and also reduce and increase both fibrosis markers, and will also increase FGF19 in the gut. So a measure of target engagement is a term that we use, shows that FGF19 is going up. Now, when you look at liver stiffness, or ELF score, which is a measure, which is a non-invasive blood test composite measure assessing fibrosis, they stay stable, not a significant decrease in stiffness by FibroScan over time. So now let's focus on safety. So I think we show that the effect is durable and mainly sustained, but they're not cumulative increases. Most common adverse events was pruritus. 69 patients, or 36%, experienced a serious treatment-emergent adverse events, and you can see 4 had variceal hemorrhage and a few other with various miscellaneous findings. 2 deaths occurred during this long-term follow-up period. 1 was related to sepsis from a heart replacement, and 1, Bruce, I think you'll get a chuckle out of this, is a PBC study. 1 patient had jaundice with acute alcoholic hepatitis. So you can see that pruritus was reported in 78% of the patients, fatigue in 33%, and some of the other typical symptoms that we've come to associate with OCA. But what's interesting with regard to the pruritus, though being relatively common, and I think this is the reassuring part of this, because I think pruritus is going to be an issue with this class of drugs, we can manage it. And discontinuation due to pruritus is relatively rare. So you can see here dropout is only in 4% or 8 patients. And you can see that the visual analog scores for pruritus generally stayed in the mild range during the course of treatment. So the other issue was whether there's in fact deterioration of liver function and whether patients met the endpoint that is being assessed in the ongoing COBALT trial, which is to show improvement in clinical outcomes. And so when you look at MELD score increase or other clinical outcomes, 10% actually experienced clinical outcome events. And this shows primarily a MELD increase, a few patients with variceal hemorrhage, 2 patients liver transplant, 2 patients died, and then some ascites, et cetera. So we can't really assess whether, in fact, those clinical outcomes were occurring at a lower than expected rate. So in conclusion, 6 years after treatment with OCA, there's sustained improvement in markers of cholestasis, inflammation, and liver fibrosis. Most common adverse events were pruritus and fatigue, generally mild to moderate, and low rate of liver-related morbidity. Since these patients were not cirrhotic to begin with, based on the assessment, you would not expect a very high rate of clinical events. And we don't really know whether this answers the question of whether it would reduce the need for liver transplantation. So there's a tremendous amount of interest in fibrates. These are PPAR and PPAR agonists. They can be alpha, delta, gamma, or pan-PPAR. Bezafibrate or bezafibrate is not available in the US. Fenofibrate is, but they're widely used for dyslipidemia and sort of other features of metabolic syndrome. And there's a lot of interest in examining those patients who have achieved a partial response but may need other therapies. So this was a poster, a late breaker poster from Christoph Korpaschow and others from a multi-center trial looking at the additive effects of fibrates compared with OCA in those who did not respond to the combination of OCA and URSO. So a lot of information on this slide, but I'll just go through it quickly. The aim was to assess the beneficial effects of OCA and fibrates, combination therapy, in those who had already been on OCA and URSO and still had not truly achieved a biochemical endpoint. So here's a study design. It's proof of concept, 12 weeks with a combination of OCA, fibrates, either Beza or Feno, and URSO because of incomplete response based on the Paris-2 criteria. And all these criteria use a combination of alkaline phosphatase reduction, liver enzymes, and other features to determine whether the patient is responding. They excluded patients who have been on triple therapy, those with autoimmune hepatitis. And there were 2 groups. One group got patients who received OCA as second-line therapy and fibrates as third-line. And the other group got fibrates as second-line and OCA as third-line. And then they looked at rate of change of alkaline phosphatase. So here's shown on the left, the patients who achieved normalization now, not less than 1.67, but actually normal alkaline phosphatase. And you can see that when you add, regardless of whether you start with OCA and add fibrates, or start with fibrates and add OCA, a significant proportion of patients who start triple therapy actually will achieve a normal alkaline phosphatase. And that is increasingly sort of becoming our goal, or my personal view, that we need to get the ALP or alkaline phosphatase down as much as possible. And then this shows the level according to time in the treatment group. And you can see that triple therapy starting here, here's the average alkaline phosphatase, and here's the 3-month and last visit. And you can see the alkaline phosphatase, regardless of what order they started in, is actually getting down around 100 or a little bit over 100. So I think this is the future. We're going to have second-line and maybe third-line therapies, and I would stay tuned for that. I had the opportunity to present a phase 2 study on behalf of co-authors. This study was a Gilead-sponsored study with an FXR agonist called cilofexor, and this is a non-steroidal FXR agonist. There can be steroidal or non-steroidal, and this was a phase 2 study. So the rationale for FXR agonists, as I mentioned, is key because FXR is a key regulator of bile acid homeostasis. These agonists have shown favorable effects on fibrosis, inflammation, and bile acids. And CILO is a selective non-steroidal small molecule FXR agonist. And these agonists, as I mentioned already, have anti-inflammatory and anti-fibrotic properties. And that's what makes this class of drug also attractive for other diseases such as PSC, NASH, et cetera. And for a cholestatic disease is particularly exciting because it increases the excretion of bile acids and reduces the production of bile acids. So, and that's by this beta-klotho pathway, and blocking CYP7A, as I already mentioned, reduce bile acid synthesis, and in the terminal ileum activates FXR right at the ileum by releasing FGF19, which then goes back into the liver and has insulin sensitizing and antifibrotic and anti-inflammatory effects. So the aim of this study was to evaluate the safety and efficacy of cilofexor in non-cirrhotic patients with PBC. And here's the study design. Placebo, 30 or 100 milligrams of cilofexor, 2 to 2 to 1 randomization. No biopsy was done. Patients were followed with liver biochemistry and serum markers. Here are the exclusion criteria: decompensated liver disease or presence of cirrhosis assessed by either fibrotest, imaging, or biopsy. I don't know if platelet count of cutoff of 160 was used, but they should have been. Serum ALP of 1.67 and bilirubin less than 2. So here are the safety assessments: adverse events, laboratory abnormalities, liver biochemistry, and signs of target engagement, such as C4. So suppression of C4 is another marker. An increase of FGF19 is a second marker for looking at whether a drug is effectively binding to this receptor and having the downstream effects. Measure total primary and secondary bile acids by liquid chromatography, and then these other biomarkers. So here's a study population, again, very similar to our PBC population that is represented in trials. Average age is in the mid-50s. Majority were white. Almost all were taking urso. Alkaline phosphatase tended to be a little bit higher in the 100 milligram group, but in the placebo and 30 milligram group was in the mid to upper 200s. ALT not particularly elevated. And you can see serum bilirubin is 0.5 to 0.6. Platelet counts are well in the normal range. And ELF score was in the 9.3 to 9.7. And any ELF score that is sort of over 9, mid-9, is associated with increased risk of likelihood of advanced fibrosis. And an ELF of greater than 11 or 11.6 has been associated with adverse clinical outcomes. And here's elastography showing 6.1, 7.8, and 7.8. So here's the primary endpoint, and you can see there's a modest but significant improvement in alkaline phosphatase at week 12 that appears to be dose-dependent, suggesting the drug is active. And here's the change in alkaline phosphatase over 12 weeks. These were statistically significant, but you can see that even in the higher dose group and in the lower dose group, these numbers come down, but they're still over 200 in most cases. But there is a statistically significant reduction in ALP. And when you then look at what are predictors of a greater likelihood that the patient would respond, you can look at relative change, and there's a slightly higher relative change in the higher dose group, and both of these are significant compared to placebo. And then when you look at what percentage achieved a 25% reduction, that was achieved in 19 and 17% of the lower and higher dose group. Normalization of alkaline phosphatase was not observed. But when you look at the patients who have a higher response, greater than 25% reduction, as I'll show on the next slide, there appears to be overall and a more marked reduction in GGT. And in the overall treated population, there is evidence of a trend towards reduced inflammation and clearly an evidence towards reduced CRP. So we want to see whether this drug is producing less bile acids. So as you know, the primary bile acids are quino and cholic acid, with lithocholic and deoxycholic acid being secondary bile acids. So we measured total bile acids, primary and secondary bile acids, and looked at also C4 suppression as a sign of target engagement. And you can see that C4 levels do come down. Interestingly, they came down in the placebo as well, and we're not sure why. But there's a reduction in total bile acids, a reduction in primary bile acids, which is the main thing that we're interested in, and this appeared to be dose-dependent. The FGF19 and C4 levels did not change, but there's some technical issues with regard to how you measure it, whether it's postprandial. I won't bore you with the details. When you look at the greater than 25% reduction in alkaline phosphatase subgroup, they did tend to have higher reduction in GGT, ALT, and a trend towards CRP, suggesting, in fact, that there's a link between reduction in alkaline phosphatase, anti-inflammatory response with this class of drugs. Here's a safety issue, a safety slide. You can see that adverse events were reported in 77 to 89%, and treatment emergent serious adverse events were seen in no patients. Treatment discontinuation was seen in 4 in the higher dose and 2 in the lower dose group, and these varied due to patient choice and in some patients due to pruritus, and 2 patients in the higher dose group were noted to have an elevated bilirubin, and it was stopped. So here's the pruritus slide, and you can see again there's a dose-dependent increase in pruritus, which was seen in 57% of the patients treated with the higher dose and 23% of patients treated with placebo. The others are all pretty much what you would expect, such as nasopharyngitis, headache, diarrhea, etc. And this shows pruritus divided into grade 1, 2, or 3, which will translate into mild, moderate, or severe. And you can see there's a dose-dependent increase in pruritus in this population treated with this drug. So in conclusion, in this randomized phase 2 trial of patients with PBC, 12 weeks with this non-steroidal FXR agonist resulted in improvement in serum alkaline phosphatase, reduction in other markers of cholestasis, significant improvement in AST and ALT, and the drug was well tolerated, but in PBC there's an increased incidence of pruritus compared to placebo. And in fact, there is a phase 3 trial of cilofexor for primary sclerosing cholangitis that is in the process of moving forward. So in the last few minutes, I want to talk about PSC. This is a vexing disease because we don't have a very good way of staging this disease. We've done liver biopsies, and several of the clinical trials are using biopsies as the primary outcome. But as those of you know that have practiced for a long time, liver biopsies in PSC can be quite variable. Sometimes they're normal. You see different areas of fibrosis that could be heterogeneous. So it's hard to figure out how to really stage this disease. And Olivier Chazois and others presented this very large study of what does FibroScan or transient elastography tell us as a way of staging PSC. Excuse me. So we know that stiffness correlates with histological fibrosis score, and we know that elevated baseline liver stiffness and liver stiffness changes over time are associated with adverse events in retrospective studies. And you can see, for example, in this study by Christophe Corpechot, that a cutoff level of 9.9 for liver stiffness shows a significant effect on survival rate, and also a change in liver stiffness of greater than 1.3 kilopascals per year is associated with a prediction of outcomes based on survival. So they wanted to aim prospectively at the prognostic value of liver stiffness measured by FibroScan. So here's a study design, very large study from the International PSC Study Group, 13 institutions, 11 countries. Inclusion criteria was a patient cannot be decompensated and needed the diagnosis of PSC to be fairly clear. Primary outcome was transplant-free survival, and the secondary outcomes were survival-free of transplant and liver complications, other liver disease complications, increase in serum bilirubin of greater than 6 for at least 3 months, or listing for transplant. So they used this EchoSense FibroScan machine, and the statistical analysis is shown here. A pre-specified interim analysis was performed 2 years after the last inclusion, so that's the results that they're presenting here. So over 600 patients with PSC, very nice study. 12 were excluded. 604 had a baseline FibroScan. 14% were excluded because technically the study was not adequate or they were not able to get a reading. 517 had a valid procedure, and 63 were lost to follow-up. So about 450 patients had a median follow-up of 34 months. So here's a population of the PSC group here. 42 is the average age, male 67%, large duct PSC 92%. Majority had non-advanced disease, so F3 and F4 were 12 and 7% respectively, and 3/4 were receiving ursotherapy. Bilirubin was 1.1, alkaline phosphatase was about twice the upper limit of normal, and the other tests are all consistent with what you see. Here's the liver spleen stiffness by elastography, 11.9 kilopascals with a pretty wide range. So here's what happened to these patients. 11 died, and they had only 2 non-liver related deaths. The others were related to liver disease. 28 patients underwent liver transplantation with a 4-year follow-up. What were the prognostic factors at baseline? Univariate analysis. Well, bilirubin of 1.5 or higher, hazard ratio. Hazard ratio was 1.5 for bilirubin as a predictor, not 1.5 times upper limit of normal. Alkaline phosphatase. So this is very helpful because we're debating how useful is alkaline phosphatase in being an outcome measure in clinical trials. AST, interestingly, 1.54. GGT, and then platelet count, fibrosis stage, and liver spleen stiffness, 1.06 hazard ratio. Now let's go to the multivariable analysis in patients who did not have a biopsy. So bilirubin was 1.3, alkaline phosphatase was 1.2, Mayo risk score 2.28, but Mayo risk score generally is weighted towards patients who have more advanced disease, but that did fall out as a multivariate predictor, and liver stiffness, 1.04 hazard ratio. And so when you look at elastography, 1.04 was the hazard ratio for predicting. Now, what are the numbers and what do they tell us about the likelihood of using this test clinically in our practice? So the hazard ratio of transplant-free survival based on liver stiffness of 2.5 to 9.5, 9.6 to 14.3, and greater than 14.4 is shown here before. So stiffness of greater than 14.4, here's the hazard ratio of survival probability. Here's a hazard ratio of 9.6 to 14.3, and here's 2.5 to 9.5. So it does seem to show a pretty good ability to segregate based on liver stiffness. So the predictive performance of liver stiffness assessed by an ROC curve was 0.87, and those of you that follow this stuff know that in AU-ROC, you want it to be as high as possible, and the straighter the line goes up and turns to the right, on the left side of the graph, the greater that the area under the curve is going to be approaching 90%. So anything that's 85 or higher or 0.85 or higher is good. 0.87 is actually pretty good, in my opinion. Then they said, all right, what is the optimum liver stiffness threshold to differentiate low versus high risk? So they did an ROC curve analysis, and with a negative predictive value of 0.98 and an accuracy of 0.85, the cutoff was 13.1. So that was a level above which the patient is very likely to have, very unlikely to have advanced disease, and the specificity was 85%. The positive predictive value is low. So this is a useful test for ruling out what patients don't have advanced disease. They then looked at survival free of transplant, events that occurred in 70 patients, and the same independent prognostic factors were consistent: bilirubin, alkaline phosphatase, liver stiffness, and a couple of other scores such as Mayo risk and Amsterdam Oxford score. So using this 13.1 threshold, they had an accuracy of 0.84 in combining it with these other variables. So the key takeaway slide here is it's just a large international prospective study validating prognostic value of FibroScan by PSC, and these results support the measurement of liver stiffness in clinical trials. And the next step, of course, is looking at prognostic value. And this study, I think, may help move forward the concept that the question that always comes up in clinical trials in liver disease is what has been validated to predict clinical outcomes as a surrogate endpoint, and this may move that needle forward. So in summary, obeticholic acid appears to be safe and effective for up to 6 years in PBC. Cilofexor shows activity as an anticholestatic therapeutic agent and is moving forward in a clinical trial. Fibrates, when added to OCA and URSO, significantly increase the alkaline phosphatase response in achieving normalization. And transient elastography, I think, is emerging as a useful staging technique in PSC. Thank you.